just a really brief introduction, and then Dr. Tomlinson will introduce herself also. It's very happy to have on our user forum today Dr. Julia Tomlinson, and she's going to talk about the paper that she and Dr. Kern recently published. Dr. Tomlinson is the managing director of Twin City Animal Hospital, and she's a diplomat of a lot, including the veterinary sports medicine rehab group as one of the many. And we thank her for her time. As always, guys, this is being recorded. And at the end, we hope we can have some conversation if questions are asked and needed, but it will be posted on our website in a couple of days. Dr. Julia, thank you.
Thanks, everyone. So I'm here in Minnesota, the Twin Cities metro area, standalone specialty sports med and rehab. We did this because we've been using the piezo way for a good while now, and we wanted to look back and see what was a good way of validating its effects clinically, but also looking at the ultrasonographic appearance of the tendons we treated. I love being able to image so I can measure the specific depth of what I'm targeting. So, which is sometimes really surprising, but more often than not, you can predict what size probe or what depth you're treating at. I did want to quick go through some pathophysiology, so send you all to sleep first. Oh, come on. Ooh, there's my name. So we all know collagen bundles in ground substance with variable elastin. Each tendon has very unique proportions of collagen and elastin. Some of the energy storing tendons, which are around the fetlock in the horse, but are also in the dog around the carpus and tarsus. In fact, 70-something% of the energy of propulsion in trot comes from the elastic storage and energy stored in these structures. So tendons are viscoelastic, they stretch during muscle load and recoil on release. And they're relatively avascular because of that, or probably because of that, who knows. And they're going to efficiently transfer a large force of motion without any blood vessel tearing, therefore. So because of this, oxygen consumption is about 7.5 times lower than skeletal muscle. So you can only imagine that local tissue hormones are much less in a tendon than they are in a muscle. They can carry long periods under load, under anaerobic conditions without cell damage. But this avascularity is really unhelpful for healing. We also know the blood flow declines with age. Hooray, something else to worry about as one ages, but also with increased mechanical loading over time. So they're stronger over time through this anabolic response that happens particularly in young animals, not so much in old. And then the blood flow slowly declines with age. Areas of differing vascularity, so different parts of the tendon might repair more quickly than other parts. Certainly the musculotendinous junction, it's a lot more vascular than it is mid-tendon. And also at the bony attachment, you've got some periosteal vessels coming into the tendon. So you might have more of a problem healing in a certain part of the tendon than others. We know that there's matrix in there, and we need to influence matrix composition as well as organizing collagen bundles to prevent or treat a scar after injury. The ground substance is proteoglycans, glycosaminoglycans, and glycoproteins. Sounds familiar, right? It's like cartilage. Tendons are about 70% water, but less with age. And we think that's why there's an increased risk of injury of tendons with age. So the musculotendinous junction here on the bottom, you can see, oh gosh, Remy's name was supposed to be taken off. This is a pennate muscle, so bone line at the top, at the bottom, sorry. Sorry about my multiple focal zones. I don't quite know what happened there. Sometimes I'm supervising residents and all sorts of things happens with the pictures. But you can see the endomysium moving together, almost like the central vein of a leaf, and that becomes the tendon. So that's how the tendon forms. And then at a musculotendinous junction, you've got collagen fibrils sitting in deep recesses between muscle cells. The tension generated by the myocytes or myofibers can then be transmitted directly to the collagen fibrils. So that's transmitting the force of muscle contraction through the tendon. This interdigitation is supposed to reduce the tensile stress exerted on the tendon during muscle contraction. But the musculotendinous junction appears to be the weakest point of the whole unit when you think about injury. But when they mapped the Achilles tendon, they found that the most relatively avascular portion was the one that was not healing as well. So it wasn't the musculotendinous junction that wasn't healing as well during a tendinopathy. So we don't really know if it's the weakest point from a point of view of its ability to repair after load like exercise. But what we do know is traditionally we've talked about that being the main site of injury, though on imaging, I'll definitely tell you that's not really the case. So the bony insertion or the enthesis, the fibers are going to blend with the periosteum, and the fiber orientation is different and the tendons often widen. So you're imaging something like the supraspinatus, you'll see those tendon fibers just fan out and interdigitate, and you will see as you move your ultrasound probe, you can reflect off of the tendon fibers, but you might sometimes just see black, which is the cartilage in there. So that distributes the load, and it's usually a zone of cartilage. Mineralized fibrocartilage then blends into the periosteum. So it's already got some mineral potential there. You've got unmineralized cartilage blending with the tendon, going to mineralized cartilage. So now you can see why you get mineralization, particularly at tendon insertions when you have an insertionopathy. So the supraspinatus of dogs and pigs, for example, has a wavy interface between layers of tissues from tendon to bone. That's again why you'll see these strange looking spread out fibers at the insertion, and that's normal. But there's a lot of fibrocartilage, and when we're doing shockwave, we have to think about that. If we're going through a relatively softer tissue, we're going to have a different effect than when we're going through a relatively tougher tissue with fibers that are going to have those sound waves bouncing off of them, or pressure waves, I should say more correctly. So what about sheath tendons like the biceps? So they're partially in a sheath or fully in a sheath. The biceps is partially in a sheath. So in the sheath, the direct blood supply to the tendon is even lower than the tendons that are outside of a sheath. The nutrition comes mostly from the synovial fluid, but hooray, healing is actually even worse than it is for non-sheath tendons because of this. And when we're intervening and putting things like PRP in, unless you're putting it directly into the tendon, you're going to be in trouble in a sheath because, again, it's just a fluid washing things away, and there's a rapid turnover of nutrients and hormones within those sheaths. So under minimal load, you'll see these lovely wavy collagen fibers, and it's straightening out of that crimp, which is the first 2%. Then the stretch from collagen fibril elongation is the rest of that, and that's elastic. And the structure can return to form when it's less than 4% strain. So there's less than 4% change in length. But when you go higher than that 4%, you can get microdamage. And so exercising hard, sometimes you can get this microdamage and you need time for repair. But the bad news is that muscle takes maybe, 24, sometimes 48 hours to repair. And what they found with tendons is they take up to 72 hours to repair. So you might get a disproportionate relief in an athlete. The muscle feels better, but the tendon still hasn't repaired from a bout of intense exercise. So we think what happens is this then accumulates and you end up with a tendinopathy. So beyond an 8% strain, so if you go way past that, you're going to get fibers actually macroscopically damaged. So tendon injury can be acute overload, which is pretty rare in dogs. So you can see sometimes it avulses at the bony attachment. It's not the weakest part of the tendon. It is the interface between structures of different tensile properties, which is why it's what gives a sudden acute overload. So the microdamage, you'll see fibril damage under a microscope. Maybe pathologic or physiologic, again, might result in an anabolic response. There's problems when there's inadequate recovery and repair after training. A lot of field trial dogs, for example, will train 4 days in a row, have a day off, and then may trial at the weekend. Inadequate recovery from everyday activity. But once a tendon is weakened, it's going to be overloaded by normal load. So how do we get them to recovery from microdamage? Well, number one, try to prevent microdamage. Number two, nutritional support, providing ground substance substrates such as PSGAGs, which has been shown in the horse to help tendinopathy. but it was directly injected into the tendon. Adequate rest between training sessions, that is really hard to convince people sometimes. And we don't always know what the right number is of time or amount of time. But do progress training slowly, particularly thinking about the tendon being the rate limiting factor in strengthening. The muscle will strengthen a lot quicker than the tendon. And Dr. Dana Whitlock, one of the specialists in our college, has talked about the fact that you might get a very big muscle, but a weak tendon, and that's why bodybuilders tear their tendons. Always train for the sport you compete in. We know that racehorses that were being trotted multiple days a week or run at a slow canter definitely had more injury than those who were run at race speed multiple times a week. And we would love to have early identification. There was a lot of work with thermography early on with racehorses. Thermography is unpredictable depending on the ambient temperature, wind speed, even air conditioning speed, and can be very non-specific, but it is helpful if you get a sort of controlled area and can see changes based on that dog's normal versus post-exercise. So what do we do if we need to recover from the actual macro damage? Provide a scaffold for healing. If there's a hole, I'll put PRP in there. Stimulate the endogenous stem cells. Give them adequate repair time and repair load. Now, for me, with the dogs, and we'll talk about this in the study, dogs are going to not lay up and not lift more than 1 pound and only limit their walks and not pull on leash. And so for me, in the early stages post shockwave therapy, we're really not doing very much at all, because just walking around every day is adequate load to start that fiber reorientation and the building. And then once I've confirmed healing is happening on my second image ultrasound, that's when we'll start doing specific loading exercises like push-ups for the biceps and decline push-ups eventually. Remember, it's a tendinopathy, not a tendinitis. There's little evidence of inflammatory issues. Inflammatory phase is about 3 days after injury to a tendon. And as the equine experts who do a lot more tendon stuff than me say, it's very hard to find a window to be treating that patient during that inflammatory phase. So what we kind of want to do is push the reset button on the inflammatory process. And that's where our modalities, as well as our injections, interventional injections, can help us. So the matrix is thick, it's weak, there's too much water, there's immature collagen, and it's much less organized. So how do we stimulate repair? Don't forget, we've got to stimulate endogenous stem cells, and we've got to help the matrix out. It's unclear whether providing substrates such as vitamin C, collagen, glycosaminoglycans, and HA helps. We do know directly injecting GAGs into the tendon can help. We do need this appropriate loading, which again, I will do, but I want to use my shockwave first and confirm we've got some better structural integrity before I do that. We don't really know what the appropriate load is for repair. The only real solid tendon study was dogs in the 1940s. They looked at repair after severing them flexor tendons. So this was an acute laceration as opposed to a tendinopathy. And what they found was that no load, so they were casted in flexion. They had poor tensile strength in the tendon at 4 to 8 weeks with disorganized fibers, because fibers orient along the lines of gravity. The dogs that were full weight bearing with no support had poor strength immediately, which lasted long term, even though they were sutured. And a partial weight bearing in a ground contact cast, so in a proper weight bearing position, but in a cast, had the best tensile strength. And this is where we quote it takes about 8 weeks for a tendon to repair. This is where we quote this from. So remembering that a laceration is very different to a tendinopathy, which could be cumulative microdamage over months to years. So an imbalance between the synthesis and breakdown of matrix leads to structural deterioration in the tendon. There's these hormone signalers, particularly metalloproteinases, which are enzymes that chomp up collagen and do some other things. And the imbalance may result in uncontrolled tendon damage. They try to chomp up disorganized fibers, but they don't get replaced with organized fibers. So you've got a lot of matrix and a really easily breakable tendon. Nitric oxide, is a short-lived free radical. It is required for healing. We know that in tendons, if they inhibited nitric oxide synthase, the enzyme that makes it, they had reduced healing, decreased cross-sectional area in the tendon, and easier load to failure is what I should say. Less load was required to failure. We know that both therapeutic ultrasound and shockwave therapy can increase the production of nitric oxide. And before I had my shockwave, I did use therapeutic ultrasound on tendons. My problem was walking that fine line between trying to use it effectively and not heating the periosteum. Certainly, I wanted to use ultrasound on a continuous mode because I wanted to melt those collagen crosslinks between fibers and help fiber reorientation. If you use it on pulsed mode, you don't get those thermal effects. So that's why I moved to shockwave, which is a lot easier because you can keep the probe still, or the trode still, in one place and then move in 1 centimeter or half centimeter increments down the tendon. And B, I'm not worried about the periosteum getting hot and getting mad and me burning it. Laser can also stimulate the production of nitric oxide. I have to say that unless it's an acute swollen tendon sheath, I have had no luck, even imaging before and after with laser. And I love my laser. It's great for arthritis, all those other things. But I would definitely not do it instead of shockwave on a tendon, just personal preference. So here's a lovely signaling slide here on looking at all the important things nitric oxide does. And then you can see that it's gene expression, signaling, amino acid metabolism, hormone metabolism, and oxygen species. So we know shockwave is mechanical transduction, movement of the tissue stimulates biological processes. It helps the fibroblasts, modulates nitric oxide production, helps neovascularization, which is hard in a tendon. There are some blood vessels in there, but it certainly is a short phase, they think, of neovascularization in the healing process. But it helps production of lubricin and growth factors, which are the big important ones, as well as the nitric oxide. A study of ponies, they showed that 3 hours after treatment, GAG and protein synthesis was increased. 6 weeks after shockwave treatment, it went down again. So they saw this transient stimulation of metabolism. They said after 6 weeks, it decreased significantly and GAG levels are lower than the untreated control. So they didn't know how to interpret that, but this was normal ponies. So they were looking at what happened, and it looks like it affected an increase in GAG and protein, and then the tendon normalized after a while. So that's the only study we really have looking at the mechanism in ponies very deeply, and they actually looked at the tendon and the signaling hormones. So what about evidence of treating tendinopathy? NSAIDs, this is dogs now. NSAIDs, no clinical improvement. 74% of dogs failed to respond. Surgical options, release, as they like to call it, have demonstrated variable success. Removing chunks of mineral has not shown to be very successful. Stem cell therapy, adipose-derived or bone marrow with platelet-rich plasma, displayed supraspinatus tendon fiber improvement, and that was imaged before and after. That's the CANAPS at VOSM. And treatment of shoulder tendinopathy using shockwave was validated relying on client interviews for follow-up, but not imaging for follow-up. So the only other imaging study was this one done with the stem cells, not with shockwave. So after that very long-winded explanation, I hope you're not all asleep, but get down to the study that I did with Dr. Terry Kern, part of her residency project. So we wanted to look at the appearance of particularly supraspinatus and biceps tendinopathy. We took out the dogs with medial shoulder syndrome. We just wanted to control the situation and have a reasonable retrospective study. So we looked at cases from 2016 to 2021, and it just got published this year. So now you should probably understand how long it takes to do a research project. We had to take away the cases that had concurrent or later diagnosed medial shoulder syndrome or instability. And instability is when the bones don't fit well. Syndromes where the tendons and ligaments aren't holding a normal joint together. Elbow pain and pathology was ruled out, pain or radiographic disease at the time of initial evaluation. And then we made sure to grade lameness using the AEP scale, which is a 0 to 5, 5 being non-weight bearing. We imaged all the dogs, diagnostic ultrasound before and after. And I went back and looked at those images using a retrospective scoring system. They were all recorded images, they weren't static. And then on cross sections were the only ones I had that were static. Pre and post treatment was randomized, just pulling them off of the flash drives, and they were all on various flash drives, which is how we store our images here. I didn't look at the written reports, and the scoring system, I'll put a table up in a minute, but the range was 0 to 15 for each tendon. And in addition to that, we looked at the cross-sectional area of each tendon at the level of pathology and looked at that pre and post treatment. There's a very big graph, sorry, but this is my own property ultrasound scale that I varied based on a human scale and adapted it. And so what you're looking at in the affected region is how much reduced echo density is there. So is it 30% of the cross section, 30 to 50%, or 50%? So you need a transverse view, you need to take the total cross-sectional area and then trace around all the areas that have reduced echo density. And that could be hypo to anechoic, that all counted. Then looking at fiber orientation. So you want to look at the stripes or striations of the tendon. And where you're looking at disorganization in 30% of the visible fibers. Again, the visible fibers, 30 to 50% or more than 50%. The total length affected how much of the length of the tendon was showing this level of pathology. So say the tendon is 3 centimeters long, which would be like a Labrador biceps. You would have a 1 centimeter affected length. That would be about 30%. That'd be a grade 2. Fiber definition in the affected region, whether there was fluid in the biceps sheath. Obviously, that was just a score for the biceps. Mineral in the tendon, and I just said presence or absence of mineral because quantifying mineral can be very difficult, especially within the fiber cartilage of the supraspinatus. And was it adhered to another structure? So just actively glide into a bicep stretch, aka shoulder flexion, little elbow extension, and checking those two tendons are gliding over each other. So all dogs were treated with the piezo wave 2 once weekly for 3 treatment sessions. Treatment was within 10 days of initial imaging, so the hair was actually clipped because it was clipped for imaging. The focus penetration depth was measured at imaging as close to the mid body of the tendon from the skin as possible. And so these dogs ran into the category of between 5 and 10 millimeters on the penetration depth used. The site in each tendon was treated. The length of the treatment zone was the affected area plus a buffer of 0.5 centimeter either side. That's just what I've always done to make sure I'm doing everything. I don't treat much more unaffected tendon than that because of that pony study that we really don't know how to interpret. The treatment prescription included distance to or from bony landmarks. That's how my technicians know. So I say start 1 centimeter above the point of shoulder for the biceps in the case of a dog where that tendon starts there, and go down in 1 centimeter increments. It was 500 pulses per site in the biceps, and in the supraspinatus, because it's fiber cartilage, I increased that to 750. That's just based on experience of what I've done before, and now I'm actually doing some much bigger dogs at 900 pulses, again just because of the fiber cartilaginous nature, the gel-like nature of the substance. It's going to be harder to get the effects of those pressure waves in theory. So we did treat all tendons affected. We tried to image both sides because studies a few years ago showed that 80% of dogs with pathology in the biceps region of one limb had changes in the other limb that were subclinical. Frequency was 6 pulses per second. We had stated that generally as a default to give time for the pulses to move through the tissue before we send the next one. Oh, here we go. Here's the energy flux density. That's good. So the range used was 0.117 to 0.173 millijoules per millimeter squared. So the standard deviation wasn't that big. So it wasn't that big of a difference between patients. They were only treated with that. There was restricted, which was short leash walks for elimination and preventing running, jumping, and climbing stairs for the duration. Of course, I can't control what happened at home. So here's the results. We had 4,619 medical records that we looked at during that year's period. Of that, 41 dogs had lesions of the biceps or supraspinatus or both. 30 dogs met all the inclusion criteria. The other 11 dogs had concurrent medial shoulder pathology or elbow problems, excluding them. And when we found those 41 dogs, we had actually already excluded the ones that we could see are hobbles on the invoice or something already. But then we looked at some that were diagnosed later with medial shoulder pathology that was at the re-image. Sometimes that muscle spasm prevents you from measuring that shoulder abduction very easily until you kind of treat that. And then you're like, whoa, wait a minute, they're unstable. All but 7 dogs. So most dogs had had periods of rest and nonsteroidals prior to referral. But that rest had ranged from 2 weeks to 2 months for 12 dogs that we knew of, the duration, and they were still lame despite the rest. 6 dogs had less lameness with rest, but had not resolved. And some of those dogs had had multiple periods of rest prior to referral. But all of the dogs that had been treated with rest had worsening or recurrence once normal activity resumed. So rest did not work. So we had 57 biceps, 57 supraspinatus tendons imaged. A couple of dogs were unilateral at owner request. We had 54 affected biceps tendons and 44 affected supraspinatus. 18 dogs had both sides affected with both tendons affected. 8 dogs had only one limb that had both tendons affected, and the other limb had only the biceps affected. 4 dogs had biceps pathology with no discernible supraspinatus pathology in either limb, but we interestingly had no dogs that had supraspinatus pathology in the absence of biceps pathology. We scored them lameness. We had 13 dogs with right forelimb lameness, 17 dogs with left. The duration of lameness, again, was 2 to 104 weeks, so quite a big range there. The lameness was an average of grade 2, so would be seen intermittently but consistently under certain circumstances. That was pre, and because the data wasn't normally distributed, that's why it's quoting an interquartile range and not a standard deviation. And the grade was 0 out of 5 post, though we had a range up to 0.25 on average score. So the lameness decreased clinically and significantly following piezo wave. So for the images, the post cross-sectional area was significantly lower than the pre. So you can see the cross-sectional area graph there. And the post-ultrasound scores were significantly lower than the pre. So you can see there the supraspinatus pre and post average score, or probably not the average, but close to average score is about between 6 and 8 for those dogs. And then afterwards, it was between 2 and 4, and similarly for the biceps there. Mineralization we found in 14 biceps tendon, because people always want to ask me, did the shockwave get rid of the mineral? And they're really focusing on the wrong thing. But 14 biceps and 19 supraspinatus tendons pre-treatment. And everyone that had mineral, of course, had other pathology within the tendon that was more important: loss of fiber definition, loss of density, which correlates to strength. Post-treatment, the mineralization was not seen in 10 out of those 14 biceps, but only 4 out of the 19 supraspinatus. So we know it's harder to get rid of it in the supraspinatus, which again makes sense to me because it is a cartilaginous gel as opposed to just tendon fibers. But that was the reason for me increasing some of my pulses to 950 in bigger dogs, just to see if I can make a difference. Not super worried about the presence of mineral, though. So follow-up was 3 to 12 months. Case information was available for all 30 dogs at 3 months post, and most of them were able to return to normal activity without lameness. So we had an 85.7% return to sport or work by 3 months. But one of those dogs, which affected our 85.7, was euthanized 3 months later due to an unrelated problem. 3 dogs did not return to sport. 1 developed neck pain and rear ataxia. The other one developed a gracilis strain and subsequent contracture 2 months after the forelimb therapy concluded. Lucky dog. And 1 dog had persistent shoulder regional pain, didn't respond to intra-articular medications, and the owner declined further diagnostics. At 6 months out, the 21 that we could follow up, 18 out of 21 continued to have no forelimb lameness recurrence. At 12 months, we had information for 11 of those dogs, and they had no lameness. 8 out of 9 pet dogs returned to normal activity by 3 months. 1 dog developed a carpal sprain, but recovered and returned to normal activity. And at 6 months, we had 7 of those pet dogs information available. There was no lameness. And at 12 months, we had 5 pet dogs available, and there was no lameness. So we still have a lot to understand. We don't know how these systems go wrong, but we have a good guide as therapists of what to do for treatment. And I was just going to say, don't assume one factor's therapy will guide the repair correctly. It's nice to have multiple things in our toolbox, but it's a really good thing to see that we actually were validating what we were doing with the shockwave and getting changes in cross-sectional area and ultrasound score. So I know there's a lot. I hope that was helpful, just to show you that there are positive changes in the tendons as well as positive effect on lameness with what you're doing, which you probably already know, but to get some information out there in the literature that the piezo wave is being effective was very important to me. Any questions are very welcome.
I always have a question.
Oh, that's good.
So you did 3 treatments weekly, then waited, I believe it was another 3 weeks before you followed up with ultrasound. Do you have any insight in the timing of the treatments and how important, like whether bi-weekly, weekly, or we know it's going to take at least 6 weeks to show an ultrasound difference? You know,
I haven't done bi-weekly. I was interested to hear in the lumbosacral case discussion that she was talking about doing bi-weekly. I haven't done bi-weekly, and I think some of that is a spillover. Well, a slight spillover from Versatron shockwave information in horses, but they're doing every 2 to 3 weeks. And I was trying to compromise between my ultrasound, which is twice a week, and thinking that there's going to be longer effects of shockwave based on what we know, 5+ days. So that's why I went with weekly. I do tell people if they're a long way away from me, the options are to combine PRP and shockwave, which was a study in horses where they put the PRP in first and then did the shockwave. And or to come 3 times, but it may be 10 days apart. And I've not seen any difference when I've done the 10 days apart. The combination, just 1 shockwave and PRP, and then off you go to Iowa or wherever, and then you come back 6 weeks later and image, that response is more variable. I'd really rather not do that. I think the consistency of reminding this very slow remodeling system periodically with a modality every week or so during the early healing process, early being the first half of healing for the tendons, is really important. And, you know, that was my rationale. It's not based on any massive science, though, I have to say.
It's just always it's an ongoing question, and I guess my answer is I don't feel like there's a huge difference whether you do it weekly or bi-weekly, but there is a time frame for the tendon to heal. Does that make sense?
Yeah, and so if we were doing it bi-weekly and we did it 3 weeks bi-weekly, I'd be more comfortable than if we were doing it bi-weekly for like 1 or 2 weeks and then wait, you know, because I think again you need to kind of keep kickstarting that. So when I chat about PRP as an option with tendons, I say you have to remember it only makes growth factors for 3 to 5 days. And so you're popping it in there and you're relying on the body to continue responding after that. And that's why we usually do 2 or 3 injections of PRP spaced apart. I usually space them 2 weeks apart only because I'm ex-equine surgeon, right? So I'm always freaking out about potential infection and things. And so I'm like, well, let's just wait a couple of weeks before we stick a needle in that thing again, right? So But I say that doesn't continue the remodeling that long. So if you've got an Achilles tendinopathy, it's like dropping PRP in a bucket of water over the time period that Achilles has to remodel. And so I prefer a modality for things like that. But the Achilles is its own special child, right? It's very different. It's very slow to remodel. It's under a massive load. You can't do relative rest with the Achilles unless you've got an orthosis. But then is there not enough load? And you see those gastrocs just atrophy when they're in the fixed orthosis. So for me, I just feel like Shockwave is a really nice way of reminding the body's remodeling system periodically. And I've done more. Sometimes I re-image them and they don't look great. They're usually dogs who also have medial shoulder syndrome, but we're trying to get the biceps robust enough to go in the brace, because of course these darn braces will overload the biceps. And that's how Deb Canup and I chatted really early on in the 2000s, just sort of going, oh, well, crud, we're making some of these guys worse with the hobbles. What's happening? And she was like, I'm looking at the biceps and they're getting worse. If the biceps don't look good enough at the re-image in a medial shoulder dog before we put the brace on, I'll Shockwave again more. And that usually works unless there's an anechoic defect, in which case I'll do PRP and Shockwave. But for those patients that live nearby, I'll do PRP and Shockwave, and then the next week later, Shockwave, and then PRP and Shockwave. Again, because I'm too chicken to do weekly PRP into a tendon because I don't want an infection. But that's just me.
And for you, when you choose to add PRP, it's when there's an actual hypoechoic region.
Yeah, yep. Or this long distance situation that they can only see me once and I can't find someone nearer them. Because if I can find someone nearer them with a Shockwave, I'm like, great, off you go. I mean, I'd rather it's piezo, so it's directed to where I want it completely. But I will tell them the tendon starts 1.5 centimeters above the point of shoulder and it goes down for 4 centimeters. Cover that area with your Shockwave. Yeah.
Hello. Hey, it's Dr. Brummett. Dr. Tomlinson, it was very nice to listen to your research. As a general practitioner who, as someone who was a general practitioner for years, but now does rehab, we don't have, like in my area, we don't have someone that's doing musculoskeletal ultrasound of the shoulders. So when these dogs come in, I am not the best palpator, but I'm getting better. But many times I'm just treating the biceps as well as the supraspinatus on both sides. And a minimum of 3 to 4 treatments. Usually for me, it's 2 weeks apart because I'm a solo practitioner and I'm very busy. But I see improvement. But I was going to ask you, and then you answered my question, like some of these dogs just need to have additional treatments if they're not responding like you thought. And then with the Achilles tendinopathies that we deal with, I find that I have to treat them longer. And you answered that question as well. But and we do use custom orthosis that's solid in the beginning, and then we articulate it as time goes on to help load those tendons. So I appreciate you making those comments, but it's without musculoskeletal ultrasound. Gosh, when do at what point do you feel really comfortable letting these guys, like with the Achilles tendon ruptures, when do you feel really comfortable letting them go?
Oh, with Achilles, never. I hate them. No, with the Achilles, to be honest, I often don't re-image the Achilles because I know it's going to keep looking like crud. And for me, is it going to change? I start progressively loading them when I can stand them out of the brace and I'm not seeing this toe
flexor
contraction, right?
Yeah.
But they're not doing that when they're out of the brace. And then I'm also doing the standing angle of that side versus the other. But I have to accept that if that tendon's been lengthened, you can't put the genie back in the bottle. It's not going to get as short, right? So if I've got maybe 5 to 10 degrees more flexion angle and standing in that tarsus versus the unaffected side, I'm okay with that as long as it doesn't drop further when I lift a front limb or the contralateral limb, because that's mimicking walk. And if it doesn't drop further, I'm like, okay, now it's time for me to start just a little bit of loading of you. So that's what I use. I do agree that it should be fixed with no load to start with, but I have a hard time getting these patients out of the device really a lot of the time. The motion limiter that I use with orthopets I'm maybe not supposed to mention brands, I don't know, but the little metal thing causes a lot of potential rubs. So they've got the hammock now, and I would rather use a canvas tether for that. And to be honest, I've switched to just going, okay, if you can stand out of it, then maybe just we have you stand out of it for a week. And then maybe we just have you walk 3 or 4 steps out of it for a week and go back in the fixed one. Because I've usually found when I've created motion in those things, I get an awful lot of limb rubs and sores. That may be my poor management. I don't know. It's hard. I would tell you, when it's a vet tech's dog, they do great, shockingly, because they follow all of the guidelines, right? And so vet tech's dog, these dogs get better and they get out of their orthosis, and the rest of the time they don't. But yeah, the loading for me is that just that eyeballing them standing and then lifting a contralateral limb.
Yeah. So for full disclosure, I work for Hero Braces.
Oh, right. Okay. Yeah.
Yeah. So, and I have found the same thing you have, that if we allow some motion, they do pretty good. But if you get too much motion, then sometimes it's hard to manage everything. And in my patients, I start as they start to be able to load that tendon, like you're talking about, and not drop, then we start doing more out of the brace. But then when I'm worried about them being really active, then they're back in the brace.
Right.
And that seems to work for most of my patients. We've had a number of patients within 6 to 8 months, they're out of it.
That's brilliant.
That's
brilliant. Yeah.
And then I have others that, seem to struggle more. And I suspect it's like you're talking about, that the tendon, until you mentioned it, I hadn't really thought about the tendon being stretched out to a point where it's just never going to really recover, but that totally makes sense.
Yeah. And sometimes I wish the surgeons they don't want to touch these macerated tendons, and I get it. They don't want to suture macerated tissue to macerated tissue. Their locking loop, or whatever the current tendons, a long time sutured tendon is used, I get that they don't want to, but if they removed some of that overstretched macerated portion and opposed more healthy tendon end to end, if that was possible, then that can certainly improve the outcomes. And so some of the surgeons will do that and pop a transcalcaneal screw in. And I like that, because that gives us more potential to not have that excess length long term. But most of the time, the surgeons don't want to touch them. They just want us to do an orthosis, which is fair. But the ones I got out of devices, if I'm looking at those crazy bilateral lab tendinopathies where they're just icky and swollen, then 18 months later they'll be like, oh, we did play ball with him out of it and he's got worse again, and then all of a sudden they're dropped and they're back in a device. So I'm kind of like, want to wash my hands of some of those cases. But yeah, I find Achilles particularly frustrating, even with the nice modality of having the shockwave. I think it's just ground substance and very little collagen.
And so on the front end side with the shoulder, without diagnostic ultrasound to show it's healed, you need to give it the time, X time. And then just from your tendon stretch when they're more comfortable, or so I'm looking at if they tolerate a bicep stretch, and I measure bicep stretch. So I'll measure the elbow extension with the shoulder and full flexion, because that helps me just quantify it side to side, and the comfort, like you said. And then really, really going easy on the load. So when we start those push-ups, they're front up on the stairs, rear on the floor, and we're just getting to bow down to their elbows and come back up. So they're just flexing, but not with their full body weight. And then we move on to 4 on the floor, and then we'll do a decline if they'll do it, ramp or rear on the stairs. So I'm trying to control that loading before I allow any uncontrolled off leash or anything. And then when we get through about 3 or 4 weeks of that progressive strengthening, after probably the 6-week mark post the first shockwave, then if the dog is still comfortable, examine them and not getting muscle spasm in the biceps, or if it is, it's really quickly resolving with manual therapies. My scapular glide's normal, the shoulder range of motion's normal, bicep stretch feels pretty good. Even if I have to do a little TLC to help it, that's when we start just doing recalls, just to kind of get a moderate intensity speed. I want my walks up to 30 minutes, and they've been progressing during the push-up period. And then recalls, and then we think about what is the everyday activity I'm trying to work them up to. So it takes me probably longer than a lot of people that I've chatted to, though I'm comfortable that some of the big rehab gurus take as long as I do, so it makes me feel a little better.
but it takes me approximately 6 weeks to 8 weeks of remobilization after that initial healing period. I'm looking at about 12 weeks total from first shockwave. It's hard, you know, because I'll go more conservative the more pathology I see in the tendon, but I still think if you're using a 10 millimeter probe for most sort of 50-pound dogs up, you're going to get a good target in that. And then maybe the smaller dogs, for the biceps, using 5 millimeter, but for the super, I would stick at the 10 unless it's something smaller than a corgi, just because of the depth of that fiber cartilage. And it's always the distal 2 centimeters of the super tendon that's affected. It sometimes maybe like 2.3 in a really big dog, but when I measure that, I can tell you that seems to be very routine, that it's the distal 2 centimeters of the tendon, which should help you with knowing where to put the shockwave, or just, you know, treat the whole thing. That's absolutely fair too. Yeah.
Yeah, that's my approach.
Mhm.
Treat the whole
I
thing.
treat the whole thing.
Yeah, exactly. And that it's effective for you. That's the point. You know, that's a good thing. Yeah. I appreciate everyone listening. Thank you.
I thank you so much, Dr. Tomlinson, for your time, and super excited and grateful for all your hard work in getting that paper published. So thank you so much, and thank you everybody for listening. And we'll have this up on the website in probably a week or so, so anybody who missed can see it. And I did have a lot of emails about that, but it will be there so we can all learn more. And I will re-listen to it, and have a great day.
Yeah. Take care, everyone. Have a lovely weekend, rest of the week.
Thank
Bye.
you. Thanks, Dr. Tomlinson.